FHI started 40 years ago as a primarily family planning research organization. And then over the years, we expanded our portfolio to include maternal and child health services. We got into HIV in the late 80s, and then infectious diseases in general like malaria, TB, in addition to HIV. And then to some extent, some areas in development. So we've been expanding our portfolio primarily to meet the needs of our stakeholders in the countries that we worked in. And we've always had a desire to broaden our involvement to other areas of development because we recognize that simply being in health was not enough, and that because of the underlying factors that contribute to health, such as poverty, such as illiteracy, and income, those were actually making it difficult for us to achieve our objectives. The AED acquisition was timely. I mean, it was an opportunity that helped us achieve all that and more. And so that has expanded our portfolio to nutrition, to education, to governance, to gender equity, and a whole host of new areas. The challenge now will be to make sure that we get all of those new areas to work together to help achieve the million MDGs. And so this takes a FHI from contributing to 3 MDGs now to virtually all of them. So that's significant. But most importantly, now when you go to a village or a town in Kenya or in Ghana, you can respond to the majority of the needs of the population and simply not say, I'm here just for your HIV needs, or I'm here for your family planning needs. So that's the main reason for this, that we are excited about this great opportunity. We got into NCDs initially because we started finding complications in patients that we had on treatment. We now have about 500,000 patients on treatment in 11 countries, treatment for HIV. And we started seeing complications, cardiovascular complications in these patients. Some of them are higher risk for diabetes, or higher risk for stroke, higher risk for hypertension, and some other metabolic changes. So we said, okay, we are paying close to $500 per patient per year for our patients, AIDS patients, and we wanted to avoid some of these patients dying for conditions that would have been cost a couple of dollars to treat. And we also wanted to make sure that we are addressing the comprehensive health needs of our patients that are on AIDS treatment. So we started our first pilot program in Kenya for that purpose. We're working in 5 sites in 2 provinces, reaching a population of roughly about 6,000 people who are either coming for counseling and testing for HIV, or those who were on treatment. And we work in partnership with the Ministry of Health, whose facilities these services are being provided. We work with the USAID, who was providing funding for these programs. We work with the Kenyan Cardiac Society that provided technical input, and FHI provided its own resources to get the program started. So that's the way it evolved. How can we improve the health of the patients in our programs? And that was successful. We were able to reach this particular population. The providers were happy, so happy that they eventually formed their own clubs, health clubs, that were checking blood pressure on a regular. They were having blood pressure checked on a regular basis. They were exercising, so they found it interesting and exciting to be involved. The patients found this as a one-stop shop. They will come there and they have their diabetes looked after, they will have their hypertension looked after, and they will have their HIV. Before this, they will have to go to 3 different locations within the hospital. Okay, so that was what got us started. Then we quickly realized that we have an incredible platform that has been developed for HIV delivery. HIV probably will go down as the best funded programs, vertical programs in health. You're talking about billions of dollars that continue to go into HIV, and that has resulted in platforms of improvement in the laboratory industry, improvement in supply chain management in terms of distribution of commodities and drugs. It also has established community organizations that were involved in the delivery of services. So a whole range. We have mobile services that include HIV, family planning, and they've added care for epilepsy, for hypertension, for diabetes, and other cardiovascular illnesses. And then in Nigeria, we screen women at the PMTCT programs for cancer of the cervix as well. This is VIA. You inspect, a midwife inspects the cervix, paints it with dye that shows whether there's early changes in the cervix, and then uses acetate solution to apply, all within 15 minutes. This is a technology that we are using in our program in Nigeria. And then in Ghana, Zambia, we also were screening for the risk factors for cardiovascular diseases, elevated blood pressure, high cholesterol, blood sugar, in addition to some of the behavior factors. So these are all examples of the transition from what I call vertical, the HIV, TB, malaria, or even reproductive health programs into a more comprehensive array of services that will make it easier for us to address the needs of patients, but also to make sure that it's also more efficient and easy for the average patient. One is the extent of the disease in the country. For example, if we are working in a country where the smoking levels are high, the disease burden is high, that's certainly, and HIV has to be high as well, sure, because we are only working in countries that have a big problem with HIV. So the availability of services for HIV that is well funded either by USAID or other donors. So that's, those are the two factors. Interest in the government, Ministry of Health specifically, willingness of the donor representative in the country, whether it's USAID. So far, these have been factors that have led to our decision to have some of the programs. We are hoping some of these factors will be minimized by USAID making a decision that they would like to promote the involvement of or the use of their HIV program platforms. The Global Health Initiative of the Obama administration also has expressively stated they are interested in improving platforms to deliver a whole range of services. So we are eventually this should become easier in most countries. There is also the last thing that I wanted to mention, that is there's an increasing demand from countries as well for this to happen, not specific to NCDs, but how can we strengthen their health service to deliver a variety of services rather than specific and limited interventions for certain disease problems. When we talk about integration or using the existing platforms, we don't have the intention that this is the only solution to the NCD. NCD is a hugely massive program, and let me just illustrate the point. HIV has currently about 32 million people infected with HIV. We have 2 million deaths, okay? Massive problem in some, especially in the Southern African countries. On the other hand, NCDs kill over 30 million people every year compared to the 2 million with HIV. Diabetes alone, estimate between 300 and 500 million people have diabetes. You're talking of, if you take the big four, cardiovascular diseases, cancers, COPD or chronic obstructive pulmonary diseases and diabetes alone are several times the magnitude of HIV. So integrating these diseases into an HIV platform will only scratch the surface. However, it is also an important start. NCDs deserve their own funding. They deserve their own response. Until that happens, this is one way to get started. But eventually we'll need, hopefully not vertical programs, but programs that address, for example, one of the things that we've been promoting, all the major risk factors that contribute to the big four are very similar. Smoking contributes to cancer, it contributes to chronic obstructive pulmonary disease, it contributes to stroke, it contributes to a whole host of things. So by addressing the basic factors, dietary, smoking, lack of physical activity, all those will contribute to reducing the cancers. There are a small proportion, about 20% of these NCDs that are due to infectious agents like HPV. Even though it is a cancer, immunization can take care of it. So we would like to see NCDs as addressed as a major health and economic problem. But at the same time, we also would like to make sure that we are leveraging other resources, whether they are in health, or they're in agriculture, or whether they're in nutrition, or poverty alleviation, or contribute to a multi-sectoral approach to solving the problem of NCDs. Realistically, I think within the next year, we'll still be in the process of trying to convince the world that this is a serious problem. It's a start. This week is certainly a start. And there will be a lot of political declarations, a lot of words. What we'd like to see how this words actually translate into action, how the world leaders follow this back to their countries, and not only commit politically for a national program, but also commit financial resources for it. We also like to see international support to support this. But as I think the danger here is that countries will realize that this is a massive problem, and they won't know where to start. I think one of the things that GBC Health or FHI is to help countries get things off the ground, get some things started, take part of the problem that we can solve, and not try and solve everything. Even though HIV has been very successful, it took 25 years to get this where, and it's incremental, opportunistic, and we have to take advantage of the resources that we have, which not necessarily are financial. They can be leadership, they can be community resources, and we have to take advantage of those to make things happen. Thirdly, we would need resources to get some other things started and to maintain them. And without that, we'll be simply scratching the surface. So we, the FHI360s and you, will have to join the activism community to make sure that the world continues to recognize the extent of problem and for resources to be made available. 5 years from now, I believe that NCDs would have achieved the recognition that HIV has achieved. It will have some of the resources and will be making dents in terms of addressing, but it will take us 10 to 15 years to come anywhere close to reducing obesity, reducing smoking to the levels that we want, reducing cholesterol levels. Those have to be go beyond health, public health, and it has to involve agricultural production, it has to involve nutrition, urban planning. You put places where people can walk, lifestyle changes that are permanent, that will go beyond generations. This is a long-term issue, and we should be ready to go the distance.